Welcome to the Deep Dive, your focused guide for MSRA revision. We're aiming this squarely at you today, concentrating on high-yield facts. Our topic, venous ulcers.
Exactly. Think of this as your power revision session. We're going to pull out the absolute core knowledge on venous ulcers, the what, why, how to spot them, how to manage them, all structured to help you lock it in for the exam.
Perfect. Let's get straight to it then. What's the basic definition we need to know?
Okay, so at its heart, a venous ulcer is a chronic wound, usually on the lower leg, and it's caused directly by venous insufficiency. Basically, the veins aren't doing their job properly, pressure builds up.
Right, that high venous pressure.
Exactly.
Yeah.
High venous pressure leads to tissue damage, and that's what results in the ulcer.
Okay, high pressure in the leg veins is the root cause. Where do we typically see these ulcers and what do they, look like?
You'll most commonly find them in the gaiter area, so around the ankle,
Yeah.
especially the medial malleolus, the inner ankle bone, but they can be lateral too. Appearance-wise, they tend to be shallow, maybe a bit irregular in shape, sometimes weepy or with a sort of granulating base.
And the ulcer itself, painful.
Sometimes it can be relatively painless, though the surrounding inflammation often causes discomfort. But really, you need to look at the surrounding skin that often tells the story.
The associated sign.
Yes. You'll often see clear signs of chronic venous disease, things like varicose veins themselves, venous eczema, that itchy, dry, inflamed skin. Then there's hemosiderin pigmentation.
That brownish staining.
That's the one, caused by iron leaking from capillaries. You might also see atrophy blanch, these small, white, scarred patches, and venous flare, which are like little clusters of tiny, dilated veins. Plus, edema, swelling is common, and sometimes the skin gets quite thick, even warty.
So it's a whole picture, not just the hole in the leg. It almost sounds like faulty plumbing, doesn't it?
Yeah.
Like if the one-way valves in the leg veins are leaky, blood pools, pressure builds up downstream near the skin, stresses the tiny capillaries, they leak, cause damage, and eventually the skin breaks down.
That's a really good analogy, actually. Those faulty valves let blood fall back down, especially when standing, hiking up the pressure massively in the lower leg veins, and that pressure gets transmitted right down to the skin capillaries.
Okay, so that leads us nicely into the why, the etiology. You mentioned the valves. Can you walk us through that mechanism and who's most at risk?
Right. So the core problem is that venous insufficiency. Usually because the valves in the deep or perforating veins aren't working properly, they're incompetent. This lets blood flow backwards, or retrograde.
Instead of up towards the heart.
Exactly. Which causes chronic venous hypertension, persistently high pressure in those veins. This high pressure forces fluid and big molecules like fibrinogen.
Involved in clotting, right?
Yeah, that one. It pushes fibrinogen out of the capillaries into the surrounding tissue. This forms these sort of fibrin cuffs around the capillaries, trapping them and blocking flow. That, plus the high pressure itself and the inflammation it causes, leads to impaired oxygen delivery to the tissues. Tissue hypoxia.
So the skin is starved of oxygen.
Pretty much. It gets inflamed, fragile, and doesn't take much, maybe just a small knock to break down. And once that ulcer forms, the poor oxygen supply and inflammation make healing incredibly slow.
Makes sense. Tissue needs oxygen. So who are the people most likely to end up with these valve problems or high venous pressure? What are the key risk factors we should flag?
Okay, several key ones to remember for the MSRA. A big one is a history of DVT, deep vein thrombosis, because that can directly damage the valves.
Right.
Having varicose veins already is a clear sign of underlying weakness. Obesity is important, increases pressure. Older age, as veins and valves naturally weaken. Then there's prolonged standing or sitting makes the calf pump work harder against gravity. Leg injuries can sometimes damage veins or impair that muscle pump. Pregnancy, too, temporarily raises venous pressure. And finally, family history, there's often a genetic component.
That's quite a few. Is there a good way to maybe group those or remember them easily?
Yeah, you could try Mnemonic, maybe something like VOLD-FLIP.
VLD-FLIP. Okay, break that down.
So V for varicose veins, O for obesity, L for older age, D for DVT history, then F for family history, L for long periods of standing or sitting, I for impaired calf pump, could be from injury, obesity, even pregnancy, and P for pregnancy itself.
VOLD-FLIP. Varicose veins, obesity, older age, DVT, family history, long-standing setting, impaired pump, pregnancy.
Got it. That's useful. So we've covered the causes, the risks. Let's just quickly nail down the pathophysiology again.
Sure. So the absolute root is chronic venous hypertension from those incompetent valves, high pressure. This leads straight to tissue hypoxia, not enough oxygen getting to the skin.
Which triggers inflammation. Exactly, inflammation follows. Then, because of the pressure and inflammation, fluid and proteins leak out into the tissues, causing the edema and those fibrin cuffs we mentioned. This leakage further damages the tissue structure and creates a really hostile environment for healing. The skin gets fragile, breaks down easily, ulcer forms, and then it struggles to heal. It's a vicious cycle.
Okay, pressure, hypoxia, inflammation, leakage, tissue damage, poor healing ulcer.
Got it. Now, critically, not every ulcer on the leg is venous, is it?
Absolutely not, and differentiating is key.
So if you see a leg ulcer, how do you know it's specifically a venous one and not something else? What are the main things to rule out?
Good question. The main differentials are arterial ulcers, neuropathic ulcers, especially in people with diabetes and pressure ulcers. But you also have to keep in mind less common things like vasculitis, ulcers linked to conditions like rheumatoid arthritis, and importantly, malignancy.
Malignancy. Yes, a chronic, non-healing ulcer can sometimes undergo malignant change into a type of skin cancer called a squamous cell carcinoma that's known as a Marjolins ulcer. Always needs consideration if an ulcer looks odd or just won't heal.
Okay, so how do we tell them apart based on features?
We look for the contrasts. Venous ulcers, typically shallow, gator area, maybe not too painful itself, but with all the surrounding skin changes, the pigmentation, eczema, edema. Arterial ulcers, usually much more painful, often deeper, look punched out, maybe on toes or pressure points, and crucially, you'll find weak or absent foot pulses.
Because the arteries aren't delivering enough blood.
Precisely. Neuropathic ulcers, think diabetes, often painless because of nerve damage, usually deep, typically on the sole of the foot or under pressure points, and you might see thickened skin, hyperkeratosis around the edge.
And the Marjolins ulcer.
Look for changes in a chronic wound, maybe a rolled, raised, hard edge. Any suspicion, you biopsy it. Rheumatoid ulcers can be sharp, deep, well-defined, sometimes on the top of the foot or calf.
Okay, let's try a quick scenario for the listeners. You see an elderly patient, ulcer on the front of their shin. They say it's really quite painful, it looks deeper than usual, and you struggle to feel their foot pulses, venous or leaning elsewhere.
With that combination, significant pain, deeper ulcer, and crucially, those diminished pulses, you'd be strongly suspicious of an arterial component, if not a primary arterial ulcer. It doesn't fit the classic venous picture well.
Right. That difference is vital for management, isn't it? Before we get to management, just quickly, how common are venous ulcers? Epidemiology.
They're very common, especially in older populations. Estimates suggest maybe 1 to 3% of people in the UK develop one at some point. The number of people with one right now, the point prevalence, is about 3 per 1,000 people overall.
But higher in the elderly.
Much higher. It jumps up significantly, maybe to around 20 per 1,000 in people over 80. And it's worth remembering socioeconomic factors might play a role in healing rates, possibly due to access to care or compliance.
Okay, definitely something we'll see. So let's summarize the clinical picture and diagnosis. Typical presentation.
You're looking for that patient profile. Often older, maybe obese, might mention leg heaviness, aching, swelling that's worse at the end of the day or after standing, better with elevation. History might include DVT, varicose veins, family history. Examination shows the ulcer, typically gator area, shallow, irregular, maybe weeping, surrounded by those skin changes, pigmentation, eczema, induration, maybe edema.
And diagnosis is mainly clinical?
Primarily, yes. Based on that characteristic history and the examination findings, the ulcer itself, plus the signs of venous insufficiency. And always checking the foot pulses is part of that initial assessment to help rule out significant arterial disease.
Okay, history and exam are key. What about investigations? Are they always needed?
While diagnosis is often clinical, investigations are crucial, especially one in particular before you start treatment.
Which is?
The ankle brachial pressure index, or ABPI. Absolutely essential.
Why is the ABPI so critical here?
Because the main treatment for venous ulcers is compression therapy, and you cannot safely apply strong compression if the arterial supply to the leg is significantly reduced. The ABPI measures that arterial flow by comparing ankle pressure to arm pressure.
Okay. So what ABPI value is the warning signal?
A key cutoff is 0.80. If the ABPI is less than 0.80, it indicates significant peripheral arterial disease. Applying high compression could be dangerous. It could worsen ischemia, potentially leading to tissue loss. So ABPI 0.8 generally means high compression is contraindicated or needs extreme caution and specialist input.
Less than 0.8, no high compression without specialist review. Got it. Any other pitfalls with ABPI?
Yes, there's another important one, an ABPI above 1.3.
Higher is bad too.
It usually suggests the arteries are calcified and rigid, often seen in patients with diabetes or advanced kidney disease. They don't compress properly when taking the pressure, giving a falsely high reading. So an ABPI 1.3 doesn't mean the flow is great. It means the reading isn't reliable and might be masking underlying arterial disease. It warrants caution and probably further vascular assessment before compression.
Okay, that's a really important nuance.
Yeah.
So, quick check. Patient has a typical looking venous ulcer, but their ABPI comes back at 0.6. What's the immediate implication for management?
ABPI 26 is well below 0.8. That confirms significant peripheral arterial disease. You would not proceed with standard high-level compression therapy. This patient needs urgent referral to vascular specialists to assess the arterial supply properly before any compression decisions are made.
Clear. ABPI first. Always. What other tests might be done?
A venous Doppler ultrasound is often helpful. It can directly visualize the veins and confirm reflux, that backward flow showing valve incompetence. You might measure the ulcer size regularly to track healing. Swabs are only useful if you clinically suspect infection, looking for redness, warmth, increased pain, pus.
Not routine swabbing, then.
No, definitely not. Colonization is normal. You only treat infection. Patch testing could be done if you suspect contact dermatitis from dressings or creams causing the surrounding eczema. And a biopsy is important if the ulcer looks atypical, is very large, or fails to heal after, say, 12 weeks, primarily to rule out malignancy that margins ulcer. Basic bloods like FBC, ESR, CRP might be done if you're considering other underlying causes.
Okay, that makes sense. So we've diagnosed, we've done our crucial ABPI. Now, the management, how do we actually fix these things?
Right. The goals are simple. Heal the ulcer, ease the symptoms, and stop it coming back. And the absolute cornerstone, the #1 treatment, is compression therapy.
Back to compression.
Always. Graduated compression, usually with multi-layer bandage systems initially, counteracts that high venous pressure, supports the veins, reduces edema, and improves venous return. It creates an environment where healing can actually happen. Once healed, or for prevention, compression stockings, class 1, 2, or 3, depending on the severity, are vital long-term.
Compression first and foremost. What else is involved in primary care management?
Good wound care is essential under the compression. That means debridement, cleaning away any dead tissue, slough, or pus, as that hinders healing. Then appropriate dressings. Things like hydrocolloids or foam dressings that maintain a moist wound environment are often good as they help the skin cells migrate across the wound bed.
Keep it clean, keep it moist. What about medications?
Antibiotics, but only if there are clear signs of infection. Systemic antibiotics like flucloxacillin might be used then. Definitely not for routine use on uninfected ulcers. For chronic ulcers, ones that are really struggling to heal after maybe 6 months despite good compression, there's medication called pentoxifylline.
Pentoxifylline.
Yes, it's thought to improve microcirculation. The dose mentioned is 400 milligrams 3 times a day, usually for about 6 months. And importantly, it's prescribed in addition to compression, not instead of it. Also, for that venous eczema around the ulcer, topical steroids are often needed.
Any other things mentioned, maybe less evidence-based?
The source material might mention things like aspirin as a possible adjunct, but needing more research. Therapeutic ultrasound has limited evidence. More specialist things like hyperbaric oxygen, specific sprays like Granulox, venous surgery to correct reflux in suitable patients, or skin grafting for large defects exist, but that's usually secondary care.
Okay. And when should we be referring patients on to specialists, like the vascular team?
Key times for referral include: if there's no improvement after about 2 weeks of good primary care, if the patient has diabetes or significant arterial disease, that ABPI 0.8, if you suspect malignancy or another cause like vasculitis, if the ulcer's in an unusual place, if surrounding dermatitis is really bad and not responding to steroids, or if they might be suitable for venous surgery or grafting. Basically, any concern or lack of expected progress warrants specialist input.
Right, so clear pathways exist. Wrapping up management, compression is king, wound care, pentoxifylline for stubborn cases alongside compression, treat infection, manage eczema. So what's the outlook? The prognosis?
It's quite variable, honestly. It depends heavily on the ulcer size, how long it's been there, the patient's overall health, comorbidities, and crucially their adherence to the treatment, especially the compression. Healing can take weeks, but often it takes months.
And recurrence.
That's the big challenge. While many ulcers can be healed with good care, the risk of them coming back is high if the underlying venous insufficiency isn't managed effectively long-term, primarily with lifelong compression.
How high is that risk?
Figures vary, but the source suggests maybe 45% heal by 6 months in the community, perhaps 70% with specialist care. But then 12-month recurrence rates can be anywhere from, say, 26% up to nearly 70%. It's often a relapsing condition for many people.
Wow, that high. Are there factors that predict a worse outcome? Poor prognostic signs?
Yes, definitely. Things like the ulcer having been present for more than a year that carries a very high recurrence risk, over 70%. Larger initial wound size, a history of previous varicose vein surgery, ironically, an ABPI less than 0.8 indicating mixed disease, poor calf muscle pump function if more than half the wound base is covered in fibrin, lower socioeconomic status can be a factor, and perhaps unsurprisingly, poor compliance with compression therapy.
Okay, so chronic, large ulcers, arterial involvement, and not sticking with the compression are all bad signs. What about other complications besides recurrence?
Well, infection is a major one, both local infection in the ulcer and spreading infection like cellulitis. Delayed healing itself is a complication, sometimes leading to massive wounds. Chronic pain can be significant. There's a huge impact on quality of life, mobility issues, discomfort, psychological distress, social isolation, and, as mentioned, that small risk of malignant change in very long-standing ulcers.
So given all that, prevention seems absolutely critical. How do we stop these starting, and how do we stop them coming back?
Absolutely. Primary prevention is about stopping that first ulcer. It focuses on managing venous insufficiency early, so encouraging mobility, leg elevation when resting, avoiding leg injuries, wearing supportive, well-fitting shoes, using emollients regularly to keep skin healthy, but avoiding potential sensitizers if eczema is present. Lifestyle is key too: weight management, healthy diet, stopping smoking. And for those with early signs like varicose veins or ankle swelling, starting compression hosiery early can prevent progression to ulceration.
Okay, that's stopping the first one. What about stopping it recurring after it's healed, secondary prevention?
This is crucial because of that high recurrence rate. The single most important thing is consistent, long-term wear of correctly fitted compression hosiery, often recommended for at least 5 years after healing, but realistically, for many patients, it needs to be lifelong. Managing comorbidities effectively, like diabetes or heart failure, is also important. And in some selected patients, referral for consideration of venous surgery to correct the underlying reflex might be appropriate.
So, final check for everyone listening. After a venous ulcer has healed, what is the absolute cornerstone of preventing recurrence?
Without a doubt, it's the consistent long-term use of correctly fitted compression hosiery. That's the key message for secondary prevention.
Perfect. That really sums it up. We've covered a lot of ground there: the underlying pressure problem, the valve failure, how it damages tissue, differentiating from other ulcers, the crucial role of ABPI, the management cornerstone of compression, plus adjuncts like toxophylline, the tricky prognosis and high recurrence, complications, and those vital prevention strategies. Hopefully that focused review helps consolidate the key facts for your MSRA prep.
Definitely. Understanding that pathophysiology, why compression works, and how to spot the red flags like low ABPI or atypical features, those are really high-yield areas.
Absolutely. For more free MSRA revision resources, do visit freemsra.com.
And for the full premium revision toolkit, you can head over to passthemsra.com.
Thanks for joining us for this deep dive. Best of luck with the revision.